And then I'd like to introduce my close colleague, Andy Cates, who is at WashU, and he's the director of our cardiology fellowship program. He is going to tell us about how to manage cardiac symptoms with amyloidosis. Andy, take it away.
Great. Thanks, Dan. I hope everybody can see my screen by a thumbs up, Dan, if you can see it well.
Yeah.
And I hope everybody can hear me okay also. Good, since I haven't heard otherwise, I hope everybody can hear me. Dan, thank you so much for having me here. It's really great to be able to join you and everyone this morning for this wonderful conference. Congratulations to you and the planning committee for organizing another successful meeting and for going virtual, and with going virtual really helping us go global. And look forward to spending a little bit of time with you this morning. I have no disclosures that are relevant to this talk. These are my objectives for today, and I hope to accomplish this over the course of the next 20 minutes as we talk this morning. I'm going to start by a couple questions. First, really just to get a baseline. I know we have a diverse group that's there and many people with different experiences. So I'm going to start with a very simple question, just asking which of the following best describes your understanding of the management of the cardiac symptoms associated with amyloid? None, minimal, average at best, really pretty good, or you could give this talk. And I know, looking at the attendance, there are many people out there I think who could give this talk. We'll let you vote. And Tim, I'm going to ask if, as people respond, I don't want to spend too much time on this question. Good. So if you want to show us, hopefully everybody's voted. So good, a good group, a lot of learning that could be done, and some good opportunities then. So more to the MOC questions here. So you're asked to see a 75-year-old male with recently diagnosed wild-type ATTR for recommendations regarding management of atrial fibrillation. Which of the following best describes the optimal treatment option for this patient? A, beta blockers are well tolerated. B, digoxin is the preferred drug for rate control. C, he should be anticoagulated. Or D, ablation is the best option. You know, in the real world, we'd be having some sound here. We'd be having maybe some music. And as the music expired, we could see the results. Okay, great. So the majority said he should be anticoagulated. We'll talk a little bit more about this as well during my talk. And then the second MOC question, which of the following best describes treatment options for patients with heart failure symptoms associated with cardiac amyloid? A, beta blockers are contraindicated. B, furosemide is the preferred diuretic. C, there is limited data regarding best drugs to use. D, patients tend to respond well to traditional heart failure medications. Or E, non-dihydropyridine calcium blockers are a good choice. So Tim will have you play the music. All right, so Tim will have you show the results. Great, okay, good. So good variety of answers. Most people felt that there's limited data regarding the best drugs to use. And again, we'll talk more about that this morning also. All right, so overview of what we'll talk about then over the next 20 minutes or so. First, we'll be discussing the variety of cardiac symptoms that are encountered in patients with cardiac amyloid. We'll then discuss the challenges faced in treating the most common symptoms, that is heart failure. We'll talk about arrhythmia management, including atrial and ventricular arrhythmias, as well as heart block. We'll discuss a condition which bridges the neurologic and cardiac aspects of amyloid, that is orthostatic hypotension. And finally, an entity that's more recently recognized as being associated with cardiac amyloid, that is aortic stenosis. When discussing cardiac amyloid and the cardiac symptoms associated with it, it's an important starting point to consider the myocardial infiltration involving the right ventricle and left ventricle and the restrictive cardiomyopathy that ensues, that leads to both exertional dyspnea and peripheral edema that are the hallmark symptoms associated with amyloid cardiomyopathy. Infiltration of the coronary vasculature and microvasculature can result in angina, and amyloid deposits in the atria can lead to the development of atrial fibrillation or other atrial tachycardias and the resultant symptoms of palpitations. Deposition of amyloid also results in conduction disturbances that are frequently observed in patients and can result in syncope. It's also worth noting that in the case of AL amyloid, there's a direct toxic effect on the myocardium, which can result in the development of a cardiomyopathy and resultant heart failure symptoms. And one of the reasons why AL cardiomyopathy can present more acutely than the cardiomyopathy associated with ATTR. Now, the development of heart failure symptoms heralds poor prognosis in patients with both AL and ATTR when left untreated. In fact, the patients with AL amyloid have a median survival of 13 months without treatment and 6 months from the onset of heart failure symptoms. Unlike AL amyloid, transthyretin amyloid tends to have a more protracted course with a median survival of 60 months following heart failure symptoms when left untreated. Now, heart failure management in patients with cardiac amyloid can be challenging. It relates in part, at least, that the usual medications can be relatively contraindicated. Now, we think about beta blockers, especially at higher doses or those with accompanying alpha blocking properties. They tend not to be well tolerated. They can limit the compensatory heart rate increase associated with reduced stroke volume that we see in patients with cardiac amyloid. Drugs that impact the renal angiotensin aldosterone system, including ACE inhibitors and ARBs and ARNIs, have limited data with no guideline-based recommendations, and these medications may not be well tolerated because of the development of hypotension. One group of drugs in particular, the non-dihydropyridine calcium blockers, can be poorly tolerated for a couple reasons. There can be negative inotropic effects and some of the classic descriptions of shock that can be seen with those drugs. And also they can bind to amyloid fibrils and result in heart block in some patients. And other drugs can be poorly tolerated as well, such as digoxin, which traditionally has been contraindicated also, but may at low doses play some role in treatment for atrial fibrillation. It's important to remember too that in some patients who've been on these drugs for a while, if they do develop an intolerance, that may be a clue that they may have cardiac amyloid. So again, the undiagnosed patient, newly poorly tolerated drugs that have been tolerated previously may be of some concern. Now, this next slide shows a pressure volume loop, and I don't want to go through the pressure volume loop. There's nothing more annoying on a Saturday morning than going through a pressure volume loop, but it really highlights the fact that there are alterations in the pressure volume analysis that are associated with reductions in the ability of the ventricles to perform work. Now, dietary indiscretion leads to volume overload in a large number of patients with cardiac amyloid. And so to the degree that the primary management of volume management is really sodium restriction and diuretics. Now, it's not quite as easy as it would seem, though, and overly aggressive diuretics or diuresis can result in symptomatic hypotension and worsening renal perfusion. In addition, because of the circulatory congestion and gut wall edema that can happen in the context of right-sided heart failure, GI absorption can be impaired. And so the utilization of loop diuretics with higher bioavailability, such as torsemide or bumetanide, can be preferred, often in combination with aldosterone antagonists, such as spironolactone. Of course, there are data for drugs such as spironolactone, aldosterone blockers in patients with heart failure with preserved ejection fraction. So beyond heart failure, there are high rates of arrhythmias associated with AL and ATTR cardiomyopathies. And these include atrial fibrillation and other supraventricular tachycardias, ventricular arrhythmias, and intrinsic conduction disease. Now, arrhythmias such as these are often highly symptomatic and poorly tolerated in cardiac amyloid patients and may require expedited and individualized treatment. Let's take a few minutes and discuss each of these in context. Let's start with atrial fibrillation. Of course, Afib is the most frequent and clinically relevant arrhythmia in heart failure with preserved ejection fraction, so it's not surprising that it's seen in patients with cardiac amyloid. Now, there are several mechanisms to consider as to why it's so common. The conduction abnormalities associated with tissue infiltration can disrupt myocardial conduction, either through direct deposition or by promoting adjacent myocardial fibrosis. Another proposed mechanism for the atrial arrhythmias, including Afib, is increased left ventricular filling pressures that lead to atrial wall dilatation and result in myocardial fibrosis as well. Importantly, patients with cardiac amyloid have a difficult time tolerating AV nodal agents, and with it, a narrow window of optimal heart rate for these patients. As we'll discuss on subsequent slides, intracardiac thrombus is not uncommon in these patients, and with it, an important consideration for anticoagulation, really regardless of their CHA2DS2 VASC score. Additionally, there appears to be a limited role for ablation and antiarrhythmic drug therapy. Ablation does not seem to be effective in many patients, up to 80% recurring over 30 months. And antiarrhythmic drug therapy, potentially amiodarone, if at all, doesn't yield any survival benefit. There are more recent data that suggest if one is to pursue ablation or antiarrhythmic drug therapy or cardioversion, may be more effective when performed earlier in the disease course. Just how common atrial fibrillation is with cardiac amyloid isn't entirely clear, although it's becoming more clear that it is really very common. This is a study by Longhi and colleagues out of Italy that assessed the prevalence and prognostic significance of atrial fibrillation in a mixed group of patients with AL and ATTR. There was a retrospective analysis of 260 patients with cardiac amyloid, roughly half that had AL, the remainder with ATTR. And what one can see here is that on average 15%, the mean value was 15% of patients with cardiac amyloid having atrial fibrillation. And over the course of the 1.2 years of follow-up, 11 patients subsequently developed atrial fibrillation. One can see that a significant number in the wild type group had atrial fibrillation. They're more likely to be elderly, male, and have a longer duration of heart failure than the other groups who had atrial fibrillation. Shown on the right is the survival curve over a median of 2.5 years of follow-up. Afib does not seem to impact all-cause mortality in these patients, but was strongly associated with prevalent and incident heart failure. This data was confirmed more recently in a retrospective cohort from Cleveland Clinic, looking at the impact of atrial fibrillation on a group of patients with ATTR. This looked at 380 patients who were diagnosed with ATTR and looked at the prevalence of AFib in these patients. And what one can see is in the group with hereditary ATTR, roughly half had atrial fibrillation. In the group with wild type ATTR, more than 3/4, 76%, had atrial fibrillation. One can also see that the prevalence of atrial fibrillation increased with a higher stage of ATTR. And importantly, similar to the previous slide, in the previous study, the patients who had atrial fibrillation had similar survival to those who did not have atrial fibrillation. So no difference in survival, although importantly and interestingly, those patients who were maintaining sinus rhythm did do better than those who were in atrial fibrillation. Let's talk about intracardiac thrombus. Patients with cardiac amyloid have been found to have increased risk of intracardiac thrombus. This is true for those patients in sinus rhythm. Now, the most common location is the left atrial appendage, and the best way for us to assess this is with transesophageal echo that's shown here. This lets us visualize the left atrial appendage, which we see here. We can look for other signs of risk of stroke, potentially spontaneous echo contrast. We can measure the emptying velocity of the left atrial appendage. And the concern in patients with amyloid is that loss of atrial contribution or atrial kick in the setting of diastolic dysfunction can lead to clinical deterioration and require cardioversion. It's most likely due to loss of atrial mechanical function. Now, the outcomes in these patients was looked at in a study out of Mayo published back a couple years ago that looked at patients scheduled for cardioversion and matched them with patients with ATTR and those with amyloid and those without amyloid. Roughly half had ATTR. And they actually looked at the procedural success rate in these patients. The success rate was similar, but when looking at reasons why patients could not undergo cardioversion, what was striking was that in the cardiac amyloid group, roughly 80% of those patients in the cardiac amyloid group could not undergo cardioversion because of the presence of thrombus, whereas roughly 60% in the control group didn't undergo cardioversion because of the presence and because they converted to sinus rhythm on their own. And this group in the cardiac amyloid group, 2/3 of them had AFib for less than 48 hours, and majority of them had therapeutic INRs as well. Ventricular arrhythmias appear to be common in cardiac amyloid and carry prognostic implications. The presence of premature ventricular beats, non-sustained ventricular tachycardia, or sustained ventricular tachycardia, and cardiac monitoring in patients with cardiac amyloid has been associated with arrhythmic sudden cardiac death. Now, PVCs are very common in this population, up to 2/3 in several trials, and the presence of NSVT can be seen in up to 20% of patients in some trials. Studies have shown that up to 1/2 of patients with cardiac amyloid die suddenly. However, ICD placement for both primary and secondary prevention in cardiac amyloid has not been strongly supported by guidelines. The 2015 ESC guidelines give a class 2A level evidence C for secondary prevention. The 2017 ACC AHA HRS guidelines recommend individual decision making. The reasons behind this are several. First, the most common cause of sudden cardiac death has been historically thought to be due to EMD, or electromechanical dissociation, or PEA, rather than a lethal ventricular arrhythmia. Two, cardiac amyloid may carry a higher defibrillation threshold that may be refractory to ICD therapy. And finally, a historically poor prognosis and life expectancy that's seen in this patient population. Further challenging and muddying the picture is the recent study out of Vanderbilt looking at patients with cardiac amyloid, roughly half with AL, the other half with ATTR, who received a primary prevention ICD and who did or did not looked at survival over the course of 5 years. What one can see here is that over the course of the 5 years of the study, those patients who had cardiac amyloid who received an ICD did not have any survival benefit of those patients who had cardiac amyloid who did not receive an ICD. Again, this was for primary prevention. Conduction disease is highly prevalent in cardiac amyloid, and AV conduction delay involving the His-Purkinje system appears to be more common than pure sinus node dysfunction. And deposits of TTR amyloid fiber and amyloid fibrils can infiltrate the conduction system, and a significant percentage of patients require permanent pacemaking. EP studies in patients with both AL and ATTR suggest significant prolongation of infrahis conduction despite normal sinus node function. And conduction disease is more common in wild-type cardiomyopathy than hereditary cardiomyopathy. So when we think about the indications for permanent pacing, it's the same as the ACC AHA HRS guidelines, with the common indications being sinus node dysfunction, AV block, and Afib with slow ventricular response. IV pacing, when pacing indication is present, is an attractive option, as these patients are often pacemaker dependent. Chronic RV apical pacing can result in left ventricular dysynchrony, which can be a challenge in patients as well. Now, the lower rate limit can be increased to help maintain cardiac output when there are concerns for these patients. And importantly, though, it's well documented that this is a high-risk group, and especially challenging in the ATTR group due to confounding presence of orthostatic hypotension. So Holter monitor for symptoms of syncope, presyncope, or palpitations is important. Now, I realize my time is running a little bit low here, so I'm going to skip ahead. And I talked briefly about cardiac resynchronization on the last slide. So I'll skip this slide here. Orthostatic hypotension is an important consideration for these patients and can be a hallmark feature of hereditary ATTR depending upon the specific type, prevalence of up to 40 to 60%, with symptoms ranging from lightheadedness and dizziness to loss of consciousness and syncope. The concomitant cardiomyopathy with reduced cardiac output can make this even more pronounced. So with regards to orthostatic hypotension, the way we treat this is by stopping the drugs that exacerbate symptoms. We can implement non-pharmacologic measures, utilizing specific drug therapies such as expanding intravascular volume and increasing peripheral vascular resistance. Now, our practice here has not been to use drugs like Florinef because of the concerns with intravascular volume. However, increasing peripheral vascular resistance with drugs like midodrine or droxidopa can be a very effective treatment option for these patients, and we've had good success with that. My last slide here before I get to the summary relates to aortic stenosis and cardiac amyloid. This really is an interesting phenomenon that we've seen with the prevalence of AS, of course, and cardiac amyloid associated with it increasing with age. 15% of the AS, 15% of patients who have AS may have cardiac amyloid. This was seen specifically in the TAVR trials, and roughly 30% of patients with low flow, low gradient AS may have cardiac amyloid. There are certain red flags to look at, and Dr. Gilmore alluded to this in his talk, related to specific demographics, clinical, biomarkers, ECG, echo, and MRI. In the interest of time, I won't go through this. And then these are my take-home messages, and I'm not going to go through these specifically because I think my time is running short here. and these are all available to you in the syllabus, but these are really important things to consider as we talk about managing the cardiac symptoms in patients with amyloid for medical therapy, anticoagulation, the role of pacemakers, individualized decisions regarding ICDs, the multifaceted approach to orthostatic hypotension, and lastly, thinking about cardiac amyloid in certain patients with aortic stenosis. Thank you. It's been a pleasure to talk with you this morning. I hope I shared a little bit of good information with you, and I'll be sticking around for some questions that follow. Thank you.
Great. Thank you so much, Andy. Really great presentation. And we already have a number of questions, so we'd be very interested in having you around for that session.